Today we were very pleased to have Arthur Gianelli from Mount Sinai St. Luke's joining us for a very topical discussion on the status of healthcare reform in the United States. Mr. Gianelli is the president of Mount Sinai St. Luke's, part of the Mount Sinai Health System. He earned his bachelor's degree in history from St. John's University, after which he received a Master's of Arts in Political Science from Brown University, a Master in Business Administration from Dowling College, and a Master in Public Health from Columbia University. He has held many senior executive positions for two Long Island municipalities, including serving as Deputy County Executive for Budget and Finance for Nassau County, as well as Director of Operations for the town of North Hempstead. Prior to joining Mount Sinai, Mr. Gianelli served as President and CEO of New Health, the Nassau Healthcare Corporation, a publicly run healthcare delivery system that provides high-quality care to Nassau County's most vulnerable populations. Under his leadership, New Health has earned national accolades for stabilizing its finances, improving health care, quality of care, patient outcomes, and soundly investing more than $200 million in modernizing and expanding services and facilities. Please join me in welcoming Arthur Gianelli.
So good morning. So I was talking to Bruce Sands about this presentation, and Bruce said he apologized he wasn't able to come, and he asked how the presentation was going, and I said it's sort of like live tweeting, because it's literally, I'm up, and it's true, updating the tail end of the presentation on the basis of what's happening in the newspaper today or the day before or last week. So it's a little bit of an interesting type of presentation to do, certainly topical. I hope you find it engaging. So I'm going to try to do a few things today. Now, let me just stipulate there's a lot of content in the slides. I did that on purpose because I figured to the extent that folks want to look at it afterward, they can. But I'm going to try to move through this rather quickly so that there's time for a give and take and question and answer. So in the beginning, I want to talk about both why the Obama administration, go way back to 2008 and in 2009, 2010 when the bill was passed, why the Obama administration took up the cause of health reform, what were the reasons. Then I want to talk about the Obama administration's approach to health reform, which is not just the Affordable Care Act, but certainly the Affordable Care Act constitutes a large part of what the Obama administration did. I want to talk about where I think the Affordable Care Act and those reforms succeeded. I'm going to talk about where I feel that they may have fallen short and led to the situation that we're in right now. I'm going to then move to trying to just talk a little bit about some basic insurance concepts that I think are important to understanding the debate that's happening now. And we'll talk about the major components of the American Health Care Act, challenges and problems with it, and then I'm going to try to lay out what I think could be some basic principles for a bipartisan way forward. Parenthetically, I don't know that that's what the Senate is doing, given the fact that there are no moderates in the committee that they've established for developing their bill. There are no women on the committee for developing their bill, so it's not clear that they're looking for a bipartisan way forward, but that was the approach that I was going to try to take. Again, that's a lot of material. We're going to try to pace it, try to get through it as much as we can at a pace that's reasonable, and then, as I said, to try to keep time for questions and answers. So first, I thought I'd give a little bit of, as Teresa Soriano said, street cred. So this is 2009. I was running the Nassau Healthcare Corporation. I was on the executive committee for the National Association of Public Hospitals, which is currently now called America's Essential Hospitals. So we were there lobbying then Speaker Pelosi. There you see Speaker Pelosi, and there you see me without a beard, but also with no hair even then. So I just wanted to give some sense of street credibility coming into the discussion. All right. So why was health reform necessary? I'm sure you all talked about this, so I mean, this is stuff I can move through pretty quickly. But really, it's access, cost, and quality, right? More than 50 million Americans lacked health insurance. Many more, actually it's over 100 million Americans in any particular year either didn't have health insurance or struggled financially to be able to pay for health care. That's a significant problem in a country as wealthy and as advanced as ours. So we have a lot of uninsured, but we spend twice as much as any other industrialized nation, whether you do it on a GDP basis or a per capita basis. And quality, which, there's a number of ways of defining quality, but if you think about it in terms of life expectancy, we lag behind all of the other industrialized nations who have different approaches to healthcare than we do. So just a slide here, showing what the uninsured rates were prior to the enactment of the Affordable Care Act. As you can see, they were quite high prior to the creation of Medicare and Medicaid. They went down significantly in the early 70s, but then started to creep back up, all right, and then hovered pretty much at the same level for a significant period of time prior to the passage of the Affordable Care Act. I'm not going to spend a ton of time on this slide, but what I wanted to include here were just some practices that insurance companies would use prior to the passage of the Affordable Care Act to basically keep their premiums down and allow them to remove people who are high cost or high risk from their insurance rolls, or to differentially charge them. Anything from really medical underwriting, all right, which again the Affordable Care Act essentially gets rid of. And the notion of medical underwriting is that you can start to get charged a premium on the basis of your health condition. The Affordable Care Act actually gets rid of that. There are other approaches here too that were utilized. The important point here is that to the extent that protections relative to community rating are undermined by the legislation that's passed by Congress, these kinds of practices are going to come back into, are going to be utilized again. I like this slide. This is all the other major industrialized nations in the world and the United States. And you can see the degree to which the United States is an outlier, both in terms of cost and in terms of life expectancy from birth. All right, so a significant amount of money that we spend, but yet life expectancy from birth is not what you would expect it to be, particularly compared to other countries around the globe. So what did the Obama administration do relative to health reform? They did several things, and as I said, it's not just the Affordable Care Act, although the Affordable Care Act is a critical component of the reform effort that they undertook. Well, first of all, under actually the stimulus package, the Obama administration put money and incentives out there to encourage providers to take up electronic medical records, on the theory that electronic medical records would, again in theory, improve productivity, but also obviously aggregate information, allow us to use this information for analytics and for care purposes. The Affordable Care Act created significant consumer protections for the purchase of insurance. You have dependent coverage until the age of 26, which my wife and I are quite thankful for, quite frankly. You cannot be denied coverage due to pre-existing conditions. No rescission. Rescission means that an insurance company can't, once they discover you have cancer, they can't cut you off their insurance rolls. No lifetime limits. So another practice that insurance companies would engage in is that they would cap how much you could, how much in costs you could incur, and to the extent that you go over that, then you were exposed financially. And eliminated actually the Medicare donut hole. People don't really talk about that, but if you recall from the passage of Medicare Part D, the Medicare Part D created this sort of in-between donut hole where you had coverage up front, and then there was a period where if your costs reached certain levels where you had to pay, and then if your costs reached extraordinary levels, then insurance would kick in. What the Affordable Care Act did is said, look, we want to try to get rid of that donut hole to allow people on Medicare to not have to worry about making choices between their finances and their prescription drug needs. The Affordable Care Act established a new baseline for Medicaid. All right, Medicaid, and there's a slide that I have that's I think pretty powerful a little bit later on, but Medicaid is differentially administered across the 50 states and the District of Columbia. Coverage really varies widely across the United States. What the Affordable Care Act did is said, look, we want every state to cover poor people up to 138% of the federal poverty level, and we're going to give states a significant amount of funding, 100% for the first couple of years, 90% from that point forward, to cover these additionally insured Americans. The challenge there, and this is important for how the Affordable Care Act evolved, is that the Supreme Court undermined that approach and said that the Affordable Care Act really was not giving states a choice. And they essentially rewrote that section of the Affordable Care Act to give states a choice about whether to expand Medicaid or not. And so many states have expanded Medicaid, but 19 states haven't. And the differences between those states are profound. The Affordable Care Act, by creating consumer protections and by issuing some rules of the road, essentially established viable individual markets where none existed previously. And in order to establish viable individual markets, you needed to have community rating, guaranteed issue, and a community rating guaranteed issue, you had to require everybody to get insurance, and you needed to subsidize people who were poor to be able to buy coverage. Those are four components of what's really required to create a viable individual market. Any one of those components is missing, those markets are going to be challenged. We saw that prior to the Affordable Care Act because in all states, one or more of those components were missing, and as a result, individual markets really didn't function, which was a precipitant of the Affordable Care Act. And the Affordable Care Act tried to go after cost by saying, look, we don't really know the right solution to try to reduce healthcare spending, so we're going to try a lot of experiments, and we're going to focus on incentivizing providers to change the way they deliver care. That's the way that we're going to try ultimately to reduce costs in the healthcare delivery system. So the Affordable Care Act introduced value-based payments, the hospital readmission reduction program, accountable care organizations, which was a concept that had pre-existed the Affordable Care Act. The Affordable Care Act adopted that concept, bundled payments, comprehensive primary care, and then eventually, on a bipartisan basis, surprisingly in 2015, the president signed into law the merit-based incentive payment system, which is essentially value-based payment in the Medicare program for providers, not just for hospitals. Okay, so what happened as a result of these changes? So I'm going to argue that a lot of good happened, but that there were some significant problems that we're going to address as well. So as you can see from this slide, there was significant uptake, clearly incentivized by the stimulus package that was passed under the Obama administration of acute care EHR adoption. As you can see, pretty much you have almost pretty much universal adoption of electronic medical records up through 2015 on the hospital side, and an increasing amount on the physician side as well. Now, challenges exist. The EMRs don't always talk to one another. We have difficulty exchanging patient information, et cetera. But nevertheless, this is a significant improvement from where we were back in 2008. The major accomplishment of the Affordable Care Act really, I think, is the reduction in the level of uninsured Americans. This comes from the Gallup Healthways Well-Being Index, and so this is a survey, so this is self-reported on the survey. And we reached about a height of, during this period, of about 18% of Americans uninsured, right prior to the launch of the American Healthcare Exchange. And once that was done, you saw that we reached between 10 and 11%. Different surveys have different numbers. Some surveys have this number as low as 8% uninsured. Regardless of the approach and methodology for analysis, the bottom line is we've seen a significant reduction in the level of uninsured Americans since the Affordable Care Act's passage. And this is just an example of some states and the decline that you've seen in some states as a result of the passage of the Affordable Care Act. So Kentucky, for example, which is a red state but had a blue state, but had a Democratic governor for a period of time, put in place a state-run exchange that was probably the most effective in the nation, reducing the uninsured rate from 20.4% to 7.8%. Now, subsequently, the Democratic governor, I think he gets term limited out, was replaced by a Republican governor. The Republican governor is trying to unwind some of this. So we'll see what happens. But it really was a success story for the Affordable Care Act while it was implemented. Arkansas is actually another interesting example, again, a red state. So what Arkansas did, because the governor and the legislature in Arkansas did not want to expand Medicaid in the traditional way that we would think about it, they sought what's called a Section 1115 waiver. That's a waiver of the Medicaid program. And they said, you know what, rather than expand Medicaid, what we want to do is we want to take the market, we want to take the exchange that we've created, and we want to lower the threshold for participation to lower and lower income Americans, and use the money that would have been used for Medicaid to provide subsidies for low-income Americans to purchase care on the exchange. So the administration said, you know what, that's not the way we wanted to go, but it's creative, and it's an effort to try to expand coverage from a conservative perspective, and we're going to go with it. So they actually approved that waiver, and you can see the impact. And again, that's implemented by a Republican governor and a Republican administration in Arkansas. You can see some other states as well, and significant impact that the Affordable Care Act has had on the reduction in uninsured rates. Now you can see the profound difference in the United States between those states that did expand Medicaid and those that didn't. So the expansion states had an uninsured rate in 2013 of 15.8%. That dropped to 8.2%. And you can see the non-expansion states started at a higher level, 20.2%, and dropped to 14.5%. Still a significant gap between uninsured rates for the non-expansion states and uninsured rates for the expansion states. And I clipped a map here showing which states are expansion states and which ones aren't. I mean, I think key things to note is you see the expansion states being the Northeast, the West, and the Midwest primarily, and you see the non-expansion states being, the South, the Deep South, and the middle of the country. Frankly, not surprising. Exchange enrollment was steady, and it was steady even after there was a significant spike in premiums on the exchanges in 2017. So as you can see, still above 12 million beneficiaries receiving insurance through the healthcare exchanges. So I think the key point there is it held steady even during volatile changes in premiums between 2016 and 2017. Medicaid enrollment has increased significantly in the United States, despite the fact that 19 states haven't expanded Medicaid, going from about 58 million Americans in 2013 to 74.5 million Americans in 2017. This includes Medicaid, but also the CHIP program as well. You can see that uninsured rates pursuant to the Affordable Care Act have dropped, particularly among poorer Americans. So you can see here, this is a slide that shows white Americans, black Americans, Latino Americans. The colors are by year, are stratified by year, and you can see, from 2010, 2012, right prior to the enactment of the totality of the Affordable Care Act, 2016, really a pretty dramatic reduction across the board. People with family incomes less than $48,500 have uninsured rates 10 percentage points below 2001 levels, which is, again, is an important accomplishment. So who's left that remains uninsured? There's a number of categories, right? There are folks that are actually eligible for some form of financial assistance who haven't yet taken up insurance, and that represents 43% of the folks that remain uninsured. So that's all things equal, that's a potential market to go after to try to expand the number of insured Americans. There are some that are in the coverage gap. Those are those states that didn't expand Medicaid. That's 2.6 million Americans. There are those that can't get coverage due to immigration status and other reasons as well. The Affordable Care Act actually had an interesting impact on hospital bad debt expenses. So you can see from this particular slide. If you look at the average cost for all 50 states, it's not too, you don't see too much. But if you look at the 24 states in the District of Columbia that had adopted Medicaid expansion, by that point, which is 2014, more did subsequently. You can see a significant reduction in charity care costs, modest reduction in bad debt costs. Compared to the states that didn't at that time expand Medicaid in particular, you can see that bad debt costs and charity care costs went up. So the correlation, and you see this in multiple articles that I've read on this, you see this in the correlation. The correlation between bad debt, charity care, is with the expansion of Medicaid, which is interesting. And that would make sense, right? Because if you think about it on the exchanges, you still have some financial exposure for those who are participating or purchasing insurance on the exchange versus those who are insured by Medicaid. And those who are being insured by Medicaid who weren't previously were clearly charity care and bad debt type cases that hospitals would have to grapple with. This is a reduction in bankruptcy, personal bankruptcy filings. Now you can't get more precise than this because the data, you're not really asked why you file for bankruptcy. And you could make the argument with the slide, which I think is an appropriate argument to make, that bankruptcy should have gone down as the economy improved. So that's a potential causal factor as well. Nevertheless, there's a good correlation, I think, between when the Affordable Care Act went into place and the level of personal bankruptcies that you're seeing. I put a quote in from the article that I pulled this from, where this is a bankruptcy attorney commenting in Maine, talking about that they're just not seeing the kinds of healthcare-related bankruptcy cases that they had seen previously. Spending has reduced in interesting ways. Premium costs have indeed gone up, and we're going to talk about that. But in clear ways, we've seen important reductions in healthcare spending. They have implications for folks who work in hospitals like us, but nevertheless, this is important from if you're thinking about it from a federal or from a national perspective. This is Medicare spending per beneficiary. Okay, and you can see the the annual percentage growth year over year from 2000. And you can see that what the data suggests. What the data suggests is that in 2000, 2001, 2, 3, 4, you were seeing increases that approached 10% year over year in Medicare spending, okay, per beneficiary. Now, when you start to come into the period where the Affordable Care Act was passed, you see the Medicare spending per beneficiary significantly reducing. Now, there were those that argued, when this trend was first identified, there were those that argued, well, you know what, the reason for this is the economy. But you have to then counter that and say, why would the economy per se have an impact on Medicare, per beneficiary Medicare spending? It might have an impact on other type of healthcare spending, but not necessarily Medicare spending. So I would challenge that argument. I think, and we've seen, year over year, that the reduction in annual increases in Medicare spending per beneficiary has sustained. So it's my view that all of the various changes in the Affordable Care Act, the incentives relative to providers, but also cuts to Medicare rates, which again, all of which impact us on the hospital side, have had an impact on Medicare spending per beneficiary. Medicare spending is expected to be, anywhere between $1,200, $2,400 lower by, say $2,400 by 2019 than the 2010 baseline, which was the baseline used by the Obama administration when they rolled out the Affordable Care Act. The point here is that expectations about Medicare spending going out into the future have really started to decline. And you can see the gap here, all right? It's really profound between what the CBO was projecting Medicare spending was going to be. And remember, these projections, I don't want to glide over this. These projections drive policy, all right? So when the government is projecting that Medicare spending is going to grow at extraordinary rates, that's when you start to get calls for, entitlement reform, for changing the age of eligibility, or for increasing the amount that older Americans would have to contribute towards their health insurance. So these kinds of estimates have profound policy implications. So if you start to change the baseline of the projected rate of growth, which clearly has happened as a result of the Affordable Care Act, it changes how we think about what we've got to do from a policy perspective, both to provide health care for Americans, but also to manage our federal expenses. Readmission rates have gone down significantly since the passage of the Affordable Care Act, principally due to the fact that there's a focus related to the fact that there's a penalty associated with a failure to reduce readmission rates in hospitals. CMS estimates that the Affordable Care Act had significant impacts on quality, 2.1 million fewer hospital-acquired conditions. They claim $20 billion in healthcare reduction costs and 87,000 patient lives saved. Those are all obviously all estimates. What I did try to put on the right, though, is a snapshot from 2010 to 2013 of reductions in a variety of different hospital-acquired conditions. So you can see that, again, the incentives that were in the Affordable Care Act have helped to induce hospitals to adopt safer practices, and there's results in the data. We've also seen significant growth in alternative delivery models, such as accountable care organizations. There are 838 accountable organizations, care organizations at the beginning of 2016, and that's all in, that's all payers. That's not just Medicaid, Medicare Shared Savings Program. 28.3 million lives covered in some form or fashion by accountable care organizations, again, all payers. And there are significant lives covered, and you've seen significant bleed from the government payer space into the private payer space. In fact, most of the accountable care organizations exist in the commercial payer space, even though they were introduced in Medicare through the Affordable Care Act. And then we've seen the passage of MACRA, which is essentially value-based payments, but tied to physicians in the Medicare space as well. I do want to note that one of the important features of the current Medicaid structure and, in fact, the Affordable Care Act is waiver authority. Section 1115 in Medicaid, Section 1332 in the Affordable Care Act. Both provide significant waiver authority to to states, to change the rules of Medicaid or the Affordable Care Act within certain limits in order to change the delivery system. We see this here in New York in the district program that's pursuant to a Medicaid waiver, and that was approved by the Obama administration. And you actually see it in places like Vermont. So Vermont attempted, I don't know if you guys know this, but Vermont actually attempted to pass a single payer plan. And the problem was that the taxes that they needed to raise to fund a single payer plan were deemed too politically risky by the governor and by the legislature in Vermont. So Vermont backed off, and they didn't pursue a single payer plan there. But what they decided to do was to say, you know what, let's try to back into a single payer plan. Let's do that, all right, by leveraging the two waiver types, the Section 1115 waiver and the Section 1332 waiver, and let's create essentially one price for services. So in other words, it's not that commercial payers can pay you one price, Medicare is going to pay you another price, Medicaid is going to pay you another price. Rather, you're going to get one price. Service is going to equal a certain price. And there's price transparency, and it's uniform across the board. So one payer is not privileged over another payer, which is very different than the market here, say in New York, where we need the pricing from the commercial payers in order to be able to support and cross-subsidize shortfalls from Medicaid and from Medicare. This is a complex structure, but it's a backdoor way of trying to actually get into a single payer plan in Vermont, leveraging the waiver authority in the Affordable Care Act and in the Medicaid program. So some problems with the Affordable Care Act, all right, significant exchange premiums that existed in 2016 and 2017. Why? Well, there was adverse selection. We didn't get as many younger people joining up as was originally anticipated. That changed the market from what was expected. Importantly, the Affordable Care Act included what were called risk corridors, which were ways of, if you ever went bowling with kids and you have the bumpers on the side to make sure that the bowling balls don't go into the gutters. That's what risk corridors are for insurance companies. It's to make sure that prices don't go in the gutter. Prices don't go too far into the extreme. The problem is that what Congress did, frankly, to undermine the Affordable Care Act, is that they said, you know what? If the risk corridor program can't pay for itself, the government can't add money. So when that happened, what occurred subsequently is that the insurance companies had no choice but to raise premiums. So we need to keep that in mind. You know, when people complain about the Affordable Care Act and rate increases, it's true, but there were mechanisms to protect against those increases that were not adequately funded by Congress. Nevertheless, the rates that are being charged now, if you go back to the original CBO projections, are essentially what they were then. All right, so the rates are not beyond what the original projections had anticipated. Medicaid expansion is incomplete. 32 states in the District of Columbia have expanded Medicaid, the rest have not. That has undermined or weakened the impact of the Affordable Care Act. Significant red state opposition, and this is important because I don't think this was properly anticipated, quite frankly, by the authors of the Affordable Care Act. The reality is that health care is local and is administered through states. And at the end of the day, if states don't want to support the exchanges or states don't want to support Medicaid, there's not a ton that the federal government can do about it. All right, so the states where there's high level of cooperation between the federal government and state governments, those states and their markets and their Medicaid programs are working okay. In those states where there's not that level of cooperation, there's challenges. I think that needed to have been better anticipated. The individual mandate is inadequate, okay? And you can see that in the uptake by younger Americans for exchange plans in the Affordable Care Act. The ACA passed with no Republican support, which means exactly what's happening right now, that as soon as Republicans get into political control, they're going to want to change things. Parenthetical note, as soon as the Democrats get back into control, they're going to want to change things again. So if we keep going down this road, we're going to be going back and forth between fundamentally different approaches to the administration of health care. The ACA has only recently garnered public support after it was on life support and threatened by the current administration. And plans are withdrawing from exchanges in certain counties and states, which has made it challenging to be able to run, obviously, the exchanges. So I'm going to move through a couple of these slides. I did want to show this slide, though, just to show the impact of not expanding Medicaid just for a second. So these are states that have not expanded Medicaid, and that's what their Medicaid levels are. All right, so Alabama funds Medicaid at 18% of the federal poverty level. All right, so you can see basically what that means. If an individual is $12,000, you would get 18% of $12,000. And that's, if your income is above that, you are not eligible for Medicaid. So for these states, if your income is anywhere between 18, so let's take Alabama, 18% of the federal poverty level and 138% of the federal poverty level, you are eligible in the United States right now for precisely nothing. No support. All right, because of the decision not to expand Medicaid in those states. So the impact of the failure to expand Medicaid is really profound. All right, I'm going to move through this. So, big picture differences between sort of the Democrats' approach to health care and the any Republican alternatives. The Democrats emphasize the importance of coverage, all right? That health care is a right and that coverage is important. The Republicans emphasize the importance of choice. Their view is that health care is a choice. You can choose to get whatever level of health care you can get given the means that are available to you. That it's not per se a right, and therefore it's not per se an obligation of the government. That's important because that's basically an irresolvable philosophical conflict between folks that are elected to represent this country. The ACA emphasizes provider incentives to try to control cost. All right? That we're gonna change the way providers are paid so that they're induced to deliver high quality at the lowest possible price point. And that's the way that we're gonna bend the cost curve. What Republicans say is the way you're gonna get costs down is twofold. One, have the consumers have more skin in the game, have them act like consumers, all right? And number two, give them options on plans. So you know what? A young person doesn't need all the plan benefits that the Affordable Care Act requires. They can buy less. And that could potentially lower their cost, except if there's an emergency and all of a sudden they have an uncovered benefit, right? But that's the approach. And the role of government, clearly the Democrats feel that the federal government has an important role to play in the administration of health care in the United States. Republicans make an argument that the federal government has a role, but they want to devolve more of this to the states, and that the states should take their proper role, sort of administering insurance, et cetera, which is historically what they've done, and that the United States, the federal government is sort of usurping that responsibility. So Republicans control Congress, Republicans control the presidency, and the House of Representatives last week, I guess it was, passed their version of health reform called the American Health Care Act. And the key components, the key things as takeaways of the American Health Care Act are the individual mandate is eliminated and replaced with a temporary premium surcharge on those who fail to maintain continuous coverage. All right, so the idea here is we're not going to mandate you to get insurance, but we're going to give you an incentive to keep it. All right, and for whatever reason you don't keep it, then the insurance companies can charge you a premium. But even then, they can only do that for a period of time. So right away you can see if the Affordable Care Act's mandate was weak, this is substantially weaker, and that's important. Medicaid expansion is phased out. All right, Medicaid funding is capped. All right, and then provided to states on a per capita basis tied to an inflation rate from that point forward. The ACA taxes are effectively repealed, all right, and those dollars, I mean, if you've been following the news on this, the purpose was to try to use those dollars to revise the baseline for the calculation of the impact of tax reform, which the House and the Senate also want to take up. Tax credits were shifted from being income-based to being age-based. So you get more credits as you're older under the American Health Care Act. The Affordable Care Act doesn't take that approach. Rather, it gives you more funding if you have lower income. The Affordable Care Act allows for some deviation from community rating according to age on a 1 to 3 level. The American Health Care Act allows you to go up to, I think, 1 to 5. And the American Health Care Act includes provisions, as did the Affordable Care Act, for reinsurance or for high-risk pools to help in the event that you have high-cost patients that are uninsurable under this scheme. Now, a critical amendment was passed to be able to get support in the House of Representatives. The amendment basically says that states can waive two things. They can waive community rating, and they can waive essential health benefits. So it's important to note this. The amendments don't say, all right, that we're going to waive the pre-existing condition protection, but they get at that through the back door. What they say is you can waive community rating, and they say, but for the following, but for gender, age beyond the 5-to-1 ratio, and health status, unless the state establishes a high-risk pool or participates in a federal equivalent. So what that means in English is that, that's policy speak. In English, what that means is, look, you can't waive community rating for health status, but you can, the exception is, if you create a high-risk pool or you participate in some sort of high-risk pool or reinsurance program. So that's why when you see folks go up on television and say, absolutely not, the American Health Care Act does not get rid of the pre-existing condition protection, that is technically correct without being actually correct. All right, so it's an important distinction. All right, so they're right by the technical language of the bill, but wrong by the policy implications, and that's what's going on there. So you see that the government has included provisions for high-risk pools or for reinsurance, or what they call the federal invisible risk-sharing program. So the implications of this bill are profound, and I don't think are particularly partisan, as this comes from the CBO. So you saw the impact that the Affordable Care Act had on the level of uninsured Americans, dropping it to historic lows. Basically, under the bill, before it was amended, it is expected we're basically going to get back up to where we were in terms of our uninsured rates. I have to be honest, the way the bill was amended, I think that will get even worse. So this is, I found this chart in, I think in the Los Angeles Times, and I thought this was really interesting. So this is the impact of the change in the tax credits by age and by money, okay? So just follow. So if you go up to the top bar, all right, it says basically, you know, no change is sort of white. The more purple you get, it means it's a reduction in tax credits. The more orange you get, it's an increase in tax credits. So what this essentially says is that because of the structure of the American Health Care Act, poorer Americans, regardless of age, get far less money. Higher income Americans, not high income Americans, but certainly higher than the 20,000, higher income Americans, to say 50 or 75,000, get more money, and if you're older, you get substantially more money. So the folks that benefit here are older, are older if you have money. If you don't have money and you're older, it's really a problem. And younger if you have money. Those are the folks that benefit. So this is an analysis that essentially comes from the CBO. This is not, again, it's not a partisan analysis. It just was laid out well in the LA Times. So this is an estimate done of what the impact could potentially be of the fact that community rating can be waived, and therefore what you could essentially differentially charge people with certain kinds of disorders. So, you know, if you had a heart attack, you could put almost a 1,400% surcharge on your premium, just as an example. Cancer, a 3,500% surcharge. Again, what's important to note here is that community rating prohibited this kind of differential pricing, but the impact of that, you have to keep in mind, the impact of that is that the person who's young and healthy and doesn't have any of these things, they're going to all in pay more money than they would if they weren't charged on the basis of their health status. So it's an important point to understand. So those folks are going to pay a ton more under that kind of an approach, but you know, in theory, younger or healthier people wouldn't. Challenge is that, or the theory, right, in the American Health Care Act is to say, look, okay, but we're going to have these high-risk pools or reinsurance or the invisible risk-sharing program. All of those things together would provide sufficient funding to be able to cover folks that are high cost. The problem is that the amount of money that is currently in the bill is inadequate, shortfall by approximately $192 billion. Now that's correctable, all right, but it's a significant shortfall. Okay, so I'm not going to go through this, but I did want to draw your attention to this slide because I spent some time trying to think it through. And this is, if you listen to the rhetoric or you listen to the discussion, there's a whole series of approaches to try to reduce the cost of premiums. And what I wanted to try to do was go through how they do it and whether they're truly reducing costs or whether they're shifting costs. And I would actually argue that the only way to truly reduce cost, is to improve the way we deliver care. The rest of this is just shifting who's paying at the end of the day. Get more younger people in the risk pool, you're shifting a burden to younger people. If you allow for deviation from community rating, you're shifting the burden to sick people. If the government takes up the insurance, the government's paying, which means the taxpayers are paying. The way you reduce costs in the end is you improve the system. And that's the only, to me, that's the only way on this whole list that really and truly does that. So I would make an argument that, you know, it's probably going to get worse before it gets better, frankly. That you can tell by the way the Senate has angled this, that they've created a committee to try to develop their own plan that includes no moderates and includes no women. That's by intent, all right? And the goal, I think, is to try to come up with a plan that is not as conservative or is not as that far over as the Affordable Health Care, the American Health Care Act, but conservative enough to get the conservatives to allow them to kind of push the moderates to voting for it. I think that's the strategy. I put this up here, though, because I think it's important to understand that there's virtually no overlap in philosophies between those who are advocating for a deviation from the Affordable Care Act and those who want the Affordable Care Act. Those who want the Affordable Care Act think health care is a right. Those who don't think health care is a choice. Those who want the Affordable Care Act think that the federal government should be playing a lot greater role in setting parameters. Those who don't think that the federal government needs to reduce its role. Those who want the Affordable Care Act think the government expansion of government insurance is good. Those that don't think it's bad and want to reduce it. Those who support the Affordable Care Act want to provide greater financial support to poor Americans. Those that don't want to provide greater support to poor Americans. And again, those who support the Affordable Care Act think that cost reductions come through incentives, improvements, and also in high-value networks. Those who are proponents of the American Health Care Act believe that you get reduction by consumers exercising market choices in diversity in plan types. That's important because there's nothing in the middle of the Venn diagram, all right? So my sort of humble thought, I'll conclude with this, my humble thoughts for a compromise, which is not going to happen this round, all right? This isn't close to happening. So number one, I think I would be honest, and I'll anticipate a question. There were those who passionately will argue for a single payer plan. I would argue there is no chance in the world that this Congress, anytime soon, is going to pass a single payer plan. And I would argue, in fact, that I'm not sure that we want a single payer plan, because do you want the people who are in Washington right now deciding how much to spend on health care for every single American in the United States? And that's what a single payer plan would do. So there are virtues to it, but there are real issues. And think about how roiled the country is now. All right, we hate one another right now, right? We're at each other's throats right now. Can you imagine if that's what we were taking up? I don't see how our current system with our current politicians delivers that. I would make a further argument that the way we're going right now, we're going to go back and forth like a ping pong ball. All right? Republicans will pass whatever it is that they're going to pass. They're going to lose. The Democrats will get in power. They're going to pass whatever it is that they're going to pass. And we're going to keep going back and forth and making profound changes to the way we deliver health care, yet, and that has impacts on the work that, frankly, a lot of you do each and every day. All right? It makes your jobs impossible because there's incoherence at the policy level. And certainly no certitude. We don't have confidence in how we're moving forward. So I would argue that in the end, we probably, if we're ever going to get a compromise that's on a bipartisan basis, we probably have to draw from the Cassidy-Collins bill. I don't know if anybody's familiar with the Cassidy-Collins bill, but Senator Cassidy and Senator Collins are two Republican senators, moderates, who basically came out with a bill that said, look, we're going to create a series of tracks. One track is that if a state wants to keep the Affordable Care Act, they can. Another track is we could do something different, and we could drop the individual mandate, drop the other parts of the Affordable Care Act, and we'll create sort of high-risk default, sort of high deductible default plans that everybody's automatically enrolled. So rather than have an individual mandate, we'll have an automatic enrollment strategy. I would argue in the end that any compromise that could reasonably bring Democrats along would have to either preserve the funding for Medicaid such that states that wanted to expand it would, and that states that didn't would have to do something. All right? In other words, there's a level of immorality that's associated, say, in the state of Alabama, that there's nothing being done for residents that are between 18% of the federal poverty level and 138% of the federal poverty level. So I would require that if they're not going to adopt Medicaid, do something for that population of patients, use the money to be able to do that. I would argue that you could keep the underlying ACA structure in the exchanges, but you can give waivers to allow states to experiment with different formulas for how the benefits could be distributed. I would argue that you need to keep community rating, all right? But you could allow states to put something in place other than an individual mandate, since the individual mandate, quite frankly, doesn't work as well as it was hoped. I think you have to keep the consumer protections, and I think for the most part they're going to be kept. And I would allow states to try to experiment with, for certain populations, high deductible health plans and health savings accounts. The bottom line is, what I wouldn't do is actually change much the Affordable Care Act. I would broaden the waiver language in the Affordable Care Act, which is Section 1332. The bill itself creates a vehicle to change it. And if you broaden the language, you can change the bill in profound ways. To me, that's the reasonable approach forward and could potentially get compromised. It's not going to happen right now. It's not going to happen anytime soon. We're going to go through this back and forth for a while, but that would be the approach that I would take. And by the way, that approach allows a Vermont or a Colorado or a California, if they want to go to a single payer plan, go do it, all right? And it allows other states to try different models, and then we see what happens over time. But it puts parameters around the flexibility that the states would have. All right, so that concludes my presentation. I'm happy to take comments and questions.
I'm sure there's no questions.
Well, first of all, congratulations on taking on such a difficult subject, challenging. I noticed in the media that in the last few days, they started to use the phrase, maybe they've used it before, that instead of Obamacare, we talk about Trumpcare. So it's a pretty hot subject. Here's my question. You know, I hope, that there's an active geriatric program at Mount Sinai and also in the Department of Medicine here, the geriatricians active. I'm amazed that in both the TV, the newspaper, and even in your presentation, that the fact that 50% of all healthcare dollars in America, which are spent on older people, on and by, are not more central to this debate about the cost of healthcare. It's like,
Yeah.
and what you alluded to was, oh sure, a hospital gets penalized if they readmit an old person within 30 days of discharge. Well, that's a penalty, and it's a little quiet. And then there's even quieter is that doctors get paid if they can certify that in their office they obtain advance directives about earlier death if necessary from older patients. Those are the first two steps in looking at this thing that $50 out of every $100 in America spent on healthcare are spent by 15% of the population, older people. Maybe you could comment on why we don't pay more attention to this.
So, I mean, I think that's a great point, and I would say a couple things. First of all, I think it's politically fraught. And if you recall from the debate on the Affordable Care Act, you know, there was language that talked about essentially using evidence-based medicine to determine, you know, whether certain interventions would be supported at particular times. This was characterized, if you recall, as death panels, if you recall that discussion. And once that happened and took traction, then everybody shied away from having that kind of an engaged discussion about how we spend our healthcare dollars.
Led by Sarah Palin.
That's correct. That's correct. So, you know, I did indeed glide over it, but I'll come back to the point. I do think that there's a kernel of that's really important in the Affordable Care Act, which says in the end that, well, let me back up. There's a phrasing. There's different ways to phrase, for example, the triple aim. So the triple aim talks about better health, you know, better care and lower cost, right? So sometimes they say lower cost per capita or whatever. Don Berwick talks about lower cost through improvement. And so whenever I have my triple aim slide and I have that discussion, I always use Don Berwick's phrasing because it's the only one that makes sense. Because in the end, if we're going to truly reduce what we spend in healthcare, we've got to do it by improving the way we deliver care and engaging in precisely those kinds of conversations about the dollars that we spend at end-of-life care, at other points of care, how we spend our dollars for complex patients with multiple comorbidities and mental health disorders, et cetera, and wrapping in social determinant. All of that stuff is part of how we improve the delivery system, hopefully then ultimately to change how we distribute the dollars. I would argue we're spending plenty of money on healthcare, right? I mean, the data show it. We're not allocating it right at all. I mean, that's clear. So we have to have an allocation discussion, but we're not going to get to an allocation discussion until we get through this sort of policy debate about frankly, about coverage more than anything else. And I think that the federal debate is compromising our ability to have that conversation.
But in truth, given the way they're approaching it now, where you increase the premium for elderly, and particularly elderly with disease, you're actually limiting access to care in a non-evidence-based way. And it is actually an alternative.
That is true. Absolutely, absolutely, through the back door.
Yeah.
Exactly.
Over here.
In the very beginning, you pointed out that other advanced countries are spending much less per capita and getting better results. So the question that I have is, can you identify any of the things that they are doing better that you think is politically feasible in this country?
So I think there's two things that they do, well, three things that they do that we don't do. One, in some form or fashion, and it's not necessarily single payer, but some do, but in some form or fashion, most of those countries require that everybody is covered. So everybody is in the calculation of risk, and that's important. Young invincibles and older folks are all covered. That's number one. Number two, they don't have anything like the prescription drug costs that we have here in the United States. You know, what they pay for prescription drugs are much lower, and in fact, what the United States does is effectively subsidizes all of those other countries by absorbing larger pharmaceutical costs than they do. The third part, I think, is that the government plays a larger role across the board in setting pricing. Now that has profound implications. You know, if we were required, as a hospital, for example, to live on Medicaid or Medicare, hospitals that have to live exclusively on Medicaid and Medicare, my hospital's one of them, they don't make money. All right, so we're not structured to be able to live on the rate, on the payment rates that the government currently affords. What I would argue is that that's a solvable problem. Okay, that takes political will. But if you look at the Vermont example I gave you, that's what the Vermont example is trying to get at. So whether you're a commercial payer, Medicaid or Medicare, you pay the same rate for a service under the all-payer ACO model that they're trying to establish. That's what that's trying to get to. If they're right, if their experiment is right, they should start to see moderation of cost, and they should start to see a different approach to healthcare than what we're seeing around the country. The good part about the United States is that we have the ability to experiment with things like that and see if they work. All right, Maryland is another example of a state that actually uses that kind of model. All right, where the pricing is set centrally as opposed to, commercial payers pay different than Medicaid, pay different than Medicare.
The other component, which turns out to be politically charged, which is kind of unbelievable, is primary prevention.
Correct. They emphasize, certainly, for example, the United Kingdom, and again, I'm going to say this, I'm sure there's specialists in the room, so I say this and I'll duck. Primary care physicians in the United Kingdom get paid more than they get paid here, and specialists get paid less. 50% of residents that graduate in residency in the United Kingdom go into general practice as opposed to into our specialists. I think in the United States, 9 out of every 10 residents is a specialist as opposed to a primary care physician. So, those kinds of things change the dynamic of how care is delivered.
I think there's an elephant in the room, and that is that in 1989, the insurance carriers running the Medicare program, it was announced in the Wall Street Journal and the New York Times, stole $10 billion from the Medicare program. And I was told by a government official that over the next year, the country settled with them for pennies on the dollar. The money was never given back. And no one is factoring that into the equation.
Yeah, I'm not. I just to be candid with you and say I'm not familiar enough with what you're talking about. I would say that 10 billion, though it sounds like a lot of money to us, given the size of the healthcare system, isn't a huge amount. It was worth more. It was worth more. I agree.
Thank you very much.
All right, thank you guys. Thank you.